everyone, welcome to my channel. In this video, we are going to see clinical anatomy of thorax and I have divided this topic into two parts. This is part 1. Now the first thing that is studied in thorax is the thoracic cavity. Based on the shape of the thoracic cavity as seen in transverse section of thorax, we are seeing this clinical correlation that is children are prone to pneumonia. Thoracic up to 2 years after the birth is circular in cross section. Therefore, the diameter of the thorax cannot be increased within the circumference, the length of which remains constant. Therefore, in children up to the age of 2 years, the respiration is almost entirely abdominal. Consequently, young children are prone to suffer from pneumonia after abdominal operations because they resist breathing due to pain. As a result, the secretions in the lungs tend to accumulate, which may become infected and cause pneumonia. Next thing that you study in thorax is superior thoracic aperture, which is your clinical thoracic outlet or anatomical thoracic inlet. So in anatomy, there's the clinical correlation, that is anatomical thoracic inlet syndrome or the clinical thoracic outlet syndrome or scalenus anterior syndrome or cervical rib syndrome. In this, the subclavian artery and the lower trunk of the brachial plexus arch over the first rib. So here is the lower trunk of the brachial plexus and this is your subclavian artery and this arch over this first rib. Hence they may be stretched and pushed up by the presence of a congenitally hypertrophied scalenus anterior muscles or a cervical rib. Clinical features are numbness, tingling and pain along the medial side of the forearm and hand and wasting of the small muscles of the hand due to involvement of the lower trunk of the brachial plexus. There may be ischemic symptoms in the upper limb such as pallor and coldness of the upper limb and weak radial pulse due to compression of the subclavian artery. Moving on to inferior thoracic aperture, we have diaphragm. First we will see the hiccups. They occur due to involuntary spasmodic contractions of the diaphragm accompanied by closure of the glottis. Now hiccups normally occur after eating or drinking as a result of gastric irritation. The pathological causes of hiccups include diaphragmatic irritation, phrenic nerve irritation, hysteria and uremia. So here you can see this is the normal breathing and there are the hiccups here. So normal breathing, epiglottis is open airway. Here in case of the inspiration, the diaphragm contracts and the epiglottis snaps shut and causes a hiccup. Next clinical correlation is diaphragmatic paralysis. The unilateral damage of phrenic nerve leads to unilateral diaphragmatic paralysis. The condition is diagnosed during fluoroscopy when an elevated hemidiaphragm is seen on the side of the lesion and showing paradoxical movements. The bilateral damage of phrenic nerves leads to complete diaphragmatic paralysis. It is a serious condition and it may cause respiratory failure. Moving on to the bones of the thorax, first is the manubrium sterni. Sternal puncture. Manubrium sterni is the preferred site for bone marrow aspiration because it is subcutaneous and readily accessible. The bone marrow sample is required for hematological examination. A thick needle is inserted in the upper part of the manubrium to avoid the injury to the arch of aorta which lies behind the lower part. The sternal puncture is not advisable in children because in them the plates of the compact bone of the sternum are very thin, and if the needle passes through and through the manubrium, it will damage the arch of aorta and its branches, leading to fatal hemorrhage. Then we move on to another clinical correlation of the sternum, that is funnel chest or pigeon chest. Funnel chest is pectus excavatum. It is an abnormal shape of thoracic cage in which the chest is compressed antero-posteriorly and the sternum is pushed back by overgrowth of the ribs and may compress the heart. So here the sternum is pushed back. You see the sternum is pushed back and there is anterior-posterior compression. Then there is pectus carinatum or the pigeon chest. It is an abnormal shape of the thoracic cage in which the chest is compressed side to side here. And the sternum projects forward and downwards like a keel of a boat. Next is again of sternum, mid-sternotomy. To gain the access to mediastinum for surgical operations on heart and great blood vessels, the sternum is divided in the median plane. So here, this is mid-sternotomy. And then there is sternal fracture. It is common in automobile accidents. For example, when the driver's chest is hit against the steering wheel. The sternum is often fractured at the sternal angle. The backward displacement of the fractured fragments may damage aorta, heart, or liver and cause severe bleeding that may prove fatal. Moving on to the next bone, that is the ribs. The clinical correlation here is cervical rib and the lumbar rib. Cervical rib, the costal element of the C7 vertebra, may elongate to form a cervical rib in about 5% individuals. The condition may be unilateral or bilateral. It occurs more often unilaterally and somewhat more frequently on the right side. So here you can see this is your cervical rib and this is your smaller cervical rib. On the right side, it's more oftenly seen. The cervical rib may have a blind tip or the tip may be connected to the first rib by the fibrous band or cartilage or bone. And this will compress the lower trunk or the subclavian artery, that is cervical rib syndrome. Next is lumbar rib, or it is also called as gorilla rib. It develops from the costal element of the L1 vertebra and its incidence is more common than the cervical rib, but it remains undiagnosed as it is usually does not cause symptoms. It may be confused with the fracture of transverse process of L1 vertebra. So here is your lumbar rib. Moving on to the fracture of rib. Usually the middle ribs are involved in the fracture. The rib commonly fractures at its angle, posterior angle, as it's the weakest point. Then we have flail chest or the stove-in chest. When ribs are fractured at two sides, anterior angle and let's say posterior angle, the flail chest occurs. The flail segments of the ribs are sucked in during the inspiration and pushed out during the expiration, leading to a clinical condition called paradoxical respiration. So here you can see it's sucked in and here you can see in expiration it is sucked out or pushed out, and this is paradoxical respiration. Next thing is the role of the internal mammary artery in the treatment of coronary heart diseases. Now the internal thoracic artery or the internal mammary artery is sometimes used to treat the coronary heart disease. When the segment of coronary artery is blocked by atherosclerosis, the disease arterial segment is bypassed by inserting a graft. And the graft most commonly used is taken from great saphenous vein of the lung because it's easily accessible. In some patients, the myocardium is revascularized by mobilizing this internal thoracic artery and joining its distal end to the coronary artery distal to the deceased segment. Now, this internal mammary artery or the internal thoracic artery graft is preferred over the grafts from other vessels because these grafts last long. Recently, it has been found that these arteries are also less prone to develop atherosclerosis because of their histological peculiarities. The walls of these arteries contain only elastic tissue, and the cells of the endothelial lining secrete some chemicals which prevent atherosclerosis. And the left internal mammary artery is preferred over the right internal mammary artery because it is easier to access it. Next is the posture of patient during asthmatic attack. Now, during the asthmatic attack, characterized by breathlessness or difficulty in breathing, the patient is most comfortable in sitting up, leaning forward, and fixing the arms on the bed or table. This is because in the sitting position, the diaphragm is at its lowest level, allowing the maximum ventilation. And the fixing of arms on the table fixes the scapula so that the pectoral muscles and the serratus anterior muscle may act on the ribs which they elevate. Now we are starting with pleura. First clinical correlation is pleurisy or pleuritis. It is inflammation of the parietal pleura. Clinically, it presents as pain which is aggravated by respiratory movements and radiates to the thoracic and abdominal walls. It is commonly caused by pulmonary TB. The pleural surfaces becomes rough due to accumulation of inflammatory exudate. Due to the roughening of the pleural surfaces, friction occurs between the two layers of the pleura during the respiratory movement. Thus, pleural rub can be heard with a stethoscope on the surface of the chest wall during inspiration and expiration. So here you can see this is normal pleura and inflamed pleura. The visceral pleural cavity and parietal pleura is quite inflamed as compared to this. Then we have pleural effusion. Normally the pleural cavity contains only 5 to 10 ml of clear fluid that lubricates the pleural surfaces to allow their smooth movements without friction. The excessive accumulation of fluid in the pleural cavity is called the pleural effusion. It usually occurs due to inflammation of the pleura, and the pleural effusion leads to decreased expansion of the lung on the side of the effusion. Clinically, it can be detected by decreased breath sounds and dullness on the percussion on the site of effusion. In the radiological appearance, we see when a small amount of fluid is accumulated in the costodiaphragmatic recess, as it is the most dependent part here, the costodiaphragmatic angle is widened and it is seen as radiopaque shadow with a fluid line in the chest X-ray. This may be the first indication of pleural effusion. Therefore, recesses of pleura are examined routinely in the chest radiographs. Next is thoracocentesis or the pleural tap. It is a procedure by which an excess fluid is aspirated from the pleural cavity. It is performed with the patient in the Sitting position. Usually, the needle is inserted in the sixth intercostal space in the mid-axillary line. The needle is inserted into the lower part of the intercostal space along the upper border of the ribs to prevent the injury of the intercostal nerves and vessels that are in the lower part of the above rib. The needle passes in succession through the skin, the superficial fascia, the serratus anterior muscle and intercostal muscles, and the endothoracic fascia, the parietal pleura, into the pleural cavity. Next is pneumothorax. Accumulation of the air in the pleural cavity is called pneumothorax. Now it can be spontaneous or open. In this radiograph, you can see this part. This is filled with air. Then you have spontaneous pneumothorax. As the name suggests, under this condition, the air enters the pleural cavity suddenly due to the rupture of emphysematis bullae of the lung. Open pneumothorax. This condition occurs due to stab wound on the thoracic wall, piercing the pleura, leading to a communication of air in the pleural cavity with the outside atmospheric air. Consequently, each time when the patient inspires, the air is sucked into the pleural cavity, and sometimes the clothing and the layers of the thoracic wall combine to form a valve. So the air enters through the wound during inspiration but cannot exit through it. In these circumstances, the air pressure builds up continuously in the pleural cavity on the wounded side, which pushes the mediastinum to the healthy side. So it's mediastinal shift to the healthy side. And this is called tension pneumothorax. Tension pneumothorax is characterized by collapse of the lung on the affected side and the compression of lung on the healthy side. So now we are starting with the lung. Panco syndrome. It occurs due to involvement of the structures related to the posterior aspect of the apex of the lung by the cancer of lung apex. So these are Panco tumors. Clinical features: pain along the medial side of the forearm and hand and wasting of small muscles of hand due to the involvement of ventral ramus of T1. Then there is Horner syndrome due to involvement of sympathetic chain, and there is erosion of first rib. Now the cancer of lung apex may spread to involve the neighboring structures such as subclavian or brachiocephalic vein, which can lead to venous engorgement and edema in the neck, face and arm. It can also involve subclavian artery, which compression leads to diminished brachial or radial pulse. It can also involve phrenic nerve, and due to the infiltration of the phrenic nerve, there is paralysis of hemidiaphragm. Moving on to the next thing, that is auscultation of lungs. Now there is a physiology practical in the first year, that is clinical testing of these respiratory system, clinical examination. So there you will be learning the auscultation of lung as a practical. Visualization of lungs from the surface for listening lung sounds, that is auscultation of lungs. Some key points to remember during auscultation of lung: the superior lobe of the right lung is audible above the fourth rib. So here, the middle lobe of the right lung is audible between the fourth and sixth ribs. So here, the lower lobes of both ribs are audible at or below the sixth rib on the front. So here, The inferior lobes of the right and left lungs are best examined on the back, especially in the region of the triangle of auscultation. Next, we are seeing the internal structure of lung, that is your bronchi or bronchioles. First, we will see the foreign body into the right principal bronchus, the aspiration of this foreign body into it. The inhaled foreign body usually enter the right principal bronchus because it is shorter, wider and in line with trachea. So here you can see this is quite in line with trachea as compared to this. This is your right primary bronchus and it supplies right lung. Since the inhaled foreign particle tend to enter in the right principal bronchus, it will also enter the right lung. As a result, lung abscess occurs more commonly in the right lung. Moving on to bronchoscopy. Now, bronchoscopy is a procedure in which a flexible fiber optic bronchoscope is introduced in the trachea to visualize the interior of the trachea and bronchi. The carina, a keel-like median ridge at the bifurcation of trachea, is an important landmark visible through the bronchoscope. Now, as you can see here, this is the normal image obtained while seeing through a bronchoscope. So trachea is somewhat in line with right bronchus, right principal bronchus. So this will be your right principal bronchus, this will be your left principal bronchus, and this ridge in between is nothing but your carina. The widening and distortion of the angle between the principal bronchi, distorting the position of carina, seen in bronchoscopy, is serious prognostic sign since it usually indicates carcinomatous involvement of tracheobronchial lymph nodes. The carina of the trachea is also very sensitive area for cough reflex. Now here in this diagram, you can see the management of central airway tumor or the tumor in tracheobronchial lymph nodes. So here, this is your tumor coming here, and this is your tumor that is debrided and ablated by rapid bronchoscopy. There is a reoccurrence of the tumor later on, so this is nothing but your prognosis, and there is obstruction relieved by the silicon Y stent. So basically, you need to know that bronchoscopy is useful in prognostic of the tumors occurring here in the tracheobronchial tree. Next is bronchogenic carcinoma. Now it is the commonest cancer in males, especially in chronic cigarette smokers. It usually arises from the epithelial lining of the bronchi and forms well circumscribed gray-white mass in the lung. The presence of circular shadow, popularly called the coin shadow, in the plain X-ray chest PA view may be the only finding in the otherwise asymptomatic patient. The bronchogenic carcinoma may spread to brain by arterial or venous routes. In arterial routes, the lung capillaries, then pulmonary vein, then left atrium, left ventricle, aorta, internal carotid and vertebral arteries, brain. So the venous routes, we have bronchial vein, azygos vein, external vertebral venous plexus, internal vertebral venous plexus, dural venous sinuses, and the brain. Next is emphysema. In the start of the video, we have seen pneumonia where the alveolar damage is seen. So now here we are seeing another disease where we can see the alveolar damage, but the reason is different. In pneumonia, the excessive fluid is accumulated in the alveoli. Here, the alveoli of the lungs are damaged by chemicals released by the pollutants. So clinically it presents as shortness of breath and the chest appears barrel shaped. So this is normal, and this is your infected or emphysematis alveoli. In this chest x-ray radiological appearance, this is lateral view. Here you can see this, the barrel shaped chest. There is increased antero-posterior diameter, there is flat diaphragm, and there is increased lung field lucency. Moving on to bronchial asthma. Now it is a common disease of respiratory symptom. It occurs due to bronchospasm or spasm of the smooth vessels in the wall of bronchioles that reduce the diameter of bronchioles. So here you can see these are the muscles in your lungs, in the respiratory bronchioles surrounding them, and when these muscles contract there is bronchospasm, there is narrowed airway, and there is limited airflow, inflamed thickened airway wall, and there is mucus present here. So if you see the cross section, this is your normal lumen, which is your airway passage, and here the lumen is shortened and filled with mucus, and there is thickened airway wall and the muscles are contracted. As a result, the patient has great difficulty during expiration, although the inspiration is accomplished normally. The airflow is further impeded by the presence of excessive mucus, which the patient is unable to clear because an effective cough cannot be produced. So, clinically, asthma is characterized by difficulty in breathing, dyspnea, and wheezing. Now, there are some sympathomimetic drugs like epinephrine that can cause bronchodilation and relieve the bronchial asthma. Next is bronchiectasis. This is quite opposite to the bronchial asthma. This is again a clinical condition in which the bronchi and bronchioles are dilated permanently as a result of chronic necrotizing infection, and they become filled with pus leading to airway obstruction. So here this is your normal airways passage, but this becomes dilated here, this big, but this is filled with the pus or the mucus leading to airway obstruction. The basal segments of the lower lobe are prone to this condition. Then we were studying the bronchopulmonary segments. Very important LAQ question comes on this part in your university exams, and the clinical correlation of these is the segmental resection of lungs. The knowledge of bronchopulmonary segments has led to the advancement in the conservation of lung surgery. Since each segment of these lungs, of these parts, is independent functional unit having its own bronchovascular supply, and potential planes of the separation exist between the segments. The localized chronic disease such as TB, bronchiectasis, or benign neoplasm is restricted to one segment. It is therefore possible to dissect out and remove the diseased segment, leaving the surrounding tissue intact. And this procedure is nothing but the segmental resection. Now we are moving to the mediastinum. First, we will see the normal visualization of the subdivisions of the mediastinum in chest radiograph. Now this is the lateral view of X-ray. The shadow above the sternal plane represents the superior mediastinum, and below the sternal plane will be your inferior mediastinum. The subdivisions of inferior mediastinum are middle, anterior and posterior mediastinum. Now this cardiac shadow of the heart is nothing but your middle mediastinum. Then you have retrosternal. Retro means behind. So behind sternum, you have this shadow, that is your anterior mediastinum. And retrocardiac, that is behind the heart, you have the posterior mediastinum. Then next is mediastinitis. Mediastinitis is nothing but the inflammation of the loose connective tissue of the mediastinum. The facial spaces of the neck, like the pretracheal and retropharyngeal spaces, extend below into the mediastinum within the thoracic cavity. Therefore, deep infection of the neck may spread easily into the thoracic cavity, causing this mediastinitis. Here, this is inflamed part. Next is the mediastinal syndrome. The compression of the mediastinum by tumor or cyst gives rise to a group of signs and symptoms, producing a clinical condition called mediastinal syndrome. The common causes of mediastinal syndrome are bronchogenic carcinoma, aneurysm of aorta, enlargement of mediastinal lymph nodes in Hodgkin disease. So in this diagram, you can see this tumor. Let's say it is bronchogenic carcinoma. So there is this tumor which compresses the SVC, obstructs the SVC. There is engorgement of the veins leading to facial edema and plethora, and venous distension distal to the obstruction. So the clinical features overall of this is engorgement of veins in the upper half of the body due to obstruction of SVC, dyspnea, difficulty in breathing due to compression of trachea, dysphagia, difficulty in swallowing due to the compression of esophagus, hoarseness of the voice due to compression of left recurrent laryngeal nerve, and there is erosion of bodies of the thoracic vertebrae due to pressure on the vertebral column. Next is widening of the mediastinum. Mediastinal syndrome was compression of the mediastinum, and widening of the mediastinum is quite opposite of it. Now it is often observed in chest radiographs. It occurs due to a number of reasons like hemorrhage from the lacerated great vessels like aorta and SVC following trauma, for example head-on collision. So here you can see this is widening of the mediastinum. Now, in this part, there can be widening by, let's say, esophagus carcinoma also. Massive enlargement of the mediastinal lymph nodes due to the cancer of lymphoid tissue, namely malignant lymphoma, can also lead to the widening of mediastinum. Again, there could be hypertrophy of the heart due to congestive heart failure, and it is common cause of widening of the inferior mediastinum. Then next is mediastinal shift. This mediastinal shift is seen in lung and pleural pathology. The mediastinum can be shifted to affected side or to the healthy side. Mediastinum shifts to the affected side in case of collapse of the lung and atelectasis. So this is your affected side. There is atelectasis in the patient and the mediastinum is shifted towards the affected side. Next is mediastinum shifts to the healthy side in pneumothorax or hydrothorax. So here this is your healthy side, and here the pneumothorax, this is tension pneumothorax whose chest radiograph shows shifting of the radiolucency in this side, in the healthy side. Mediastinal shift to the healthy side. Now the mediastinal shift indicates lung pathology. This mediastinal shift can be detected by palpating the trachea in the suprasternal notch. So here we come to the end of the part 1 of the thorax clinical anatomy. Thank you.